This is a lot shorter, and we're going to have some time for questions or anything for both of the lectures before I leave, and turn it over to Anil to, I think, talk about the differences between the peds and adult airway. We could have done this different, but they're obliging me because I have a flight. So, techniques. We all like techniques, right? And I should start that up. That's what is fun. I mean, I use that word literally for both of our specialties. I mean, it is often the defining characteristic of, that's one of the things. You know, it's going out of favor, I think, in the anesthesia world. I don't know why. Currently, the anesthesia world thinks that we should best be training regional block people. But I got to tell you that patients' airways didn't change. So you can, okay, but you may decide I'm going to do a block instead of a general anesthetic because it's safer, but you should have decided that all along, okay? So I'm going to look at a couple things here, and I'm going to come back to something that I didn't even have on my little short bio, but I want to clarify something. So I started about I was profoundly influenced by Silvenstool. Only Anil can understand this because of this man who was really the father of pediatric bronchoscopy in North America. And to me, there was never anything where we weren't working with ENT and anesthesia together. It just never occurred. And I don't care what surgical service I'm with, if I see a difficult airway, the first thing I'm doing is making sure my ENT colleague has seen the patient. It's an elective case most of the time. Remember, this is not walk-in, you know, off the helipad. That happens. But they're elective. Come in, introduce themselves to the parent, and look at the kid, just like I did. Okay, it takes a minute for them to do that, and and then they can say to their tech, you know, would you bring this and this in the room? So they have the equipment that they might need, okay? Because the whole issue is setting it up so you don't have a hypoxic disaster leading to a slash trach. And I'm sorry, the worst scenario as a pediatrician intensivist is the child who doesn't die, who's neurologically injured. That also, for those who just care about the dollar bill, that's way more of an important issue as far as a settlement, because it's the life of that child than a death. I'm not suggesting that you should allow death to happen, by the way. It's to prevent the whole issue. But I started doing this Airway Symposium about, I don't know, 24, 26 years ago. I didn't know any better. I wouldn't have asked anyway, but those who know me know that's my personality. I just sort of said, I'm going to do an international symposium. I'm going to have peds ENT, peds surgery, pulmonology, intensive care, and peds anesthesia. And I'm going to orchestrate this, and we're going to have a conference in DC. My department had no interest. My division had no interest. My hospital had no interest, and they still have no interest. Okay, I did it anyway. Fortunately, my wife didn't know that I charged $30,000 on the Platinum Visa card to get out of the hotel to pay for the charges, but at least I managed to pay for it with some reimbursements, okay? Because I think I wouldn't be married at that point. I might have something happen to me as well, you know. Okay, so in the long run, I had an Airway Symposium. It's still running. I'll tell you, I put a pitch in for it, but it's not mine anymore. A number of years ago, when I knew that my career was going to be ending, I'm 70 this year, I decided that it would not continue at Children's in Pittsburgh. I definitely didn't see it at CHOP, even though that's where I had lived most of my life as a trainee. But I did find a receptive audience at Denver Children's, both in the anesthesia group and the pediatric ENT group, many of which I had trained or knew because they were trained by Robin Cotton in Cincinnati. So the ENT people are knowing these names because Pittsburgh and Cincinnati literally had the two top training programs in PEDS-ENT, the top programs, because they had fellowship programs with research time for decades. There are other ENT programs that are just absolutely great. So I started the symposium, and about 10 years ago, I probably have about 100, 150 requests to actually create a pediatric airway algorithm. By the way, there isn't one, okay? And I said, hey, you guys, there's probably a dozen of us who could actually write the algorithm, more than that. And some of them have done them in chapters, but they're not legal. I said, it's the footnotes that define the algorithm. And the footnotes, each of them have 10 lawyers behind each one. I didn't have the money with the clout to do that. So there is no pediatric airway algorithm, and I make that announcement. This is, no matter what I tell you, it is not. It's my training, my view. We're just going to look at just a few things. We've done that. We've done as much as we could to eliminate the difficult airway. And I'm not going to go through all of these because you guys have all the current equipment. I just wanted to hit a couple, and then I'll leave some time. And I'm going to look at three things. I added one last night. I did look at the agenda for what was happening after today, and I figured I would talk about something that you may not use. But so we're not going to look at mask management. We know if the average adult, the average anesthesiologist doesn't manage a mask right in children. Actually, they don't do much masks in adult. I've walked over to the university hospital, and it is still all this. They push a few times, maybe with a mask. They put an LMA and intubate. They're not doing mask management, but they get away with it. You can't get away with it if you push on the soft tissue, that triangle between the mental process and back here and over here. You push on the soft tissue there. I have dozens of videos. It just happened to have this video strobe with it turned on, you know, underneath the mask in the nose, showing the distortion of the airway with our trainees managing it. Okay, it just happened to get me there. I don't know how it got turned on. Forget about, you know, IRB type stuff. So we're not going to do that. We're not going to do LMA. We know that a community anesthesiologist in England devised the LMA. Okay, a community anesthesiologist. There's the third one I added is a community anesthesiologist too. So they're not the university professors, okay, the teachers. These are people who had a problem, who spent their life looking in the minutiae and come up with a solution. I mean, this is a phenomenal thing, and it has certainly saved lives for all specialties. Now, the state of Pennsylvania is stupid because its Department of Health says that nobody other than a physician can use an LMA. The EMS people who drive into Ohio from Pennsylvania, they have LMAs, and they just happen to have that, you know, ambulance go into Ohio so they can put the LMA in. But they're not allowed to do it if they're in Pennsylvania. They're not licensed, okay? That's stupid, okay? We have fought this for years. We get nowhere. I don't know who pays these people off, okay? But I'm going to talk about this because this is not in almost any of the textbooks, and certainly didn't appear to about two plus years ago, although I've been teaching it for decades. But the story is, it goes back to Sylvan Stool again. Sorry, I have to do that. When somebody's influenced you. Sylvan was an incredible rigid bronchoscopist, and we have all these terrible airways. And I said, Sylvan, you've got a 12-inch straight pipe, and I have a 3-inch 1 Phillips, half longitudinally cut straight pipe. How come you can get to the airway and I can't? Now, Sylvan sort of jokingly said what every surgeon believes, I'm better than you, and then decided that he had better take that back. So we decided to film him. This is back, early 80s when he was at Pittsburg before he retired. Old clunker video camera, one of the ones that was this big. I know you were not born, but huge, cassettes this big, gives you 20 minutes of low resolution something or another. And I filmed him doing rigid bronchs. And then we would go look. I probably did a dozen. And we would go afterwards, at the end of the day, we would look at the video and say, I don't know what I'm doing different. I don't see it. You see it? I don't see it. And then, just out of the blue, we saw what was happening different from what the ENT people do without knowing that it's happening, and what the anesthesiologist does during the laryngoscopy. So what happens during a rigid bronchoscopy is the bronchoscope never is holding any of the tongue underneath it. That's the defining issue. It rolls over into what I call the right gutter. It's sort of aiming past the right tonsillar pillar and heads downstream, okay? Now, whether they put a laryngoscope in or not to guide it or not, this is what happens when that comes out and they're using this 12-inch pipe. Well, that's not the way we are taught to use a straight blade or even a curved blade. We're taught to have the tongue to some degree underneath there. Well, the problem with it is the tongue prevents you from getting to where you want to go. The ENT surgeons, I've talked to dozens. No one truly was conscious that that was the defining thing. It's much easier to say, I'm better than you, okay? And I said, let's do the same thing with a straight blade. And lo and behold, with the first, and I did a series, I did a laryngoscopy in every PO or man treat your Collins that came to our OR. And I was able to go from either barely a view or no view to grade 1-2 views in 93%. That's my hands, mind you. With a straight blade used incorrectly. I mean, I would have settled for 5%. So this is pretty impressive. So I'm going to show you this technique. I changed the label because for 15 years I had what the residents who would go back to our university hospital would do this. They would get screamed at by the adult anesthesiologist, threatened to kick them out of the system. But after a while, after I taught some of the adult anesthesia attendings there, if the anesthesia resident yelled, Dr. Borland said to do this, they actually let them try it. I call it the Borland bad laryngoscopy, but it really is a retromolar. So if you think of aiming for the right molar or the right tonsillar pillar with your straight blade, you cheat and you change a whole bunch of important characteristics. I found this in Sylvan's line drawings from one of the old ENT things, and actually there's his rigid laryngoscope, and it's very clear that it's on the side of the tongue. I mean, he wasn't conscious that this was even happening. So I'm trying to do this. I don't have a good video, so there's a couple stills, and this is a normal patient. But what's impressive is if you have one where you can't do anything and you get a view, that's where it's really impressive. So, sure, I'm exaggerating here for my trainee. I'm actually turning the blade because I have the room. But if there was micrognathia, a small opening, you would be lucky if you just jiggle it in, okay? And I'm heading over to the right side. And notice, if you can, you're all at the head of the bed. The tongue is now going to be way up at the left, up against the palate. That's where it's going to end. I have two sets of series, okay? And you can actually see, it's dark, but if you really look here, you can actually see the vocal cords right there. So this is a technique. I have a different set of patients. I think to try to make it look easier. Oh, there you can see that. Can you see the opening? I don't have lighting down there. It's the ambient lighting. Okay, I actually had the dentist try to do this photography because they're used to doing photography in the mouth, and I'm not a good photographer. So it's called break the rules, but that sort of defines me, doesn't it, Emil? Okay, if it doesn't work, do something else. Okay, all right, and the whole goal is to take care of the patient. That's it. I don't care about anything else. It's to take care of the patient. Okay, so what do you need? It's really simple. A long, narrow blade. a 1 Phillips or a 2 Miller. But there's another characteristic that's important. That'll be the next one. Okay, they're long, skinny. They're open blades. Okay. All Phillips blades have the bulb as you look down on the left-hand side. Most ORs have Miller blades with the bulb on the right-hand side because it's the first one in the catalog, for no other reason. There you go. Okay, and that's what the techs order, but you can get them both sides. So you want a long, skinny blade with the bulb on the left-hand side. And there's a reason for that, because it gets really crowded down there. Okay. Let's see, we have... Okay, we don't. Okay, so I only have that one view. So basically a laryngoscopy, if you can't open the mouth well, you kind of jiggle it in. You're not putting any part of the blade under the tongue, and you're heading south. It sounds like you're not doing almost anything different. What we found is that the angle of attack, like you saw in the line drawing, profoundly changes when you see it? The angle of attack to the larynx profoundly changes from when the laryngoscope has the tongue underneath it. So instead of seeing the back of the palate, the uvula, you're just going in at a different view. It also shortens the distance from the crease to the larynx. Just does. I can use a 1 Phillips blade in a 9 and a 10 and 11-year-old. Okay, I would never pass you if I said what size blade and you pick that for a routine laryngoscopy because it's too short. Okay, but I can use this for this blade. So what I'm doing is I'm cheating. I'm going on the right-hand side. Everybody will say, well, can we do it? Most of the time, if I've washed my hands, I'll kind of demonstrate in a tech area, where you're doing some of the things you're going to do this afternoon. You really are going to push your tongue out of the way and go in the right gutter, underneath the tongue, head for the right tonsillar pillar, and it drops right on the larynx. Does it work all the time? Of course not. But it's something in your pocket. Okay? Can you practice this without the surgeons knowing that you're practicing? This is important. Of course you can. With the ENT residents, not the fellows. When they're doing, half of the ENT residents, when they start with us, have never done a laryngoscopy. Remember that? Painful, isn't it? Okay, I mean, they're there, they've done other things, but they've never done a direct laryngoscopy. And you teach them how to do it well, and it's usually me or they're attending. But I also, when they're doing it, I deliberately say, I want to show you this technique. If I demonstrate this to one of the anesthesia people, I'm in the ENT room, I always bring the ENT residents and fellows over. I want to show you what you can do with this blade that is not the way it was, quote, designed to do. So I'm going to stop for a second because I only have 3 techniques, okay? And this is the one that's new. It appeared in, I think, Cote's book about 3 years ago. I've been teaching it for over 20, 25 years actively, okay? Didn't get around to writing it up. We just taught it, and we presented it at the Airway Symposium. So, again, retromolar laryngoscopy. You can even try it. Is it worthwhile doing in every normal airway? No. But you can practice it because you may have that patient with some TM joint abnormalities that doesn't translocate adequately, or maybe even has something that's in the way, like the tongue. If you can get past the tongue, okay, and you don't have the tongue underneath, you cheat, folks. Okay, and cheating is good if you save the patient's life. It's really simple. Nothing, no bones about it. Any questions of anybody? Okay. We went through these. My second thing is as much for the anesthesia. This is for the anesthesia attendings, and I think that this is an issue. So we do all of the fiber optic intubation training for the entire university system. They really don't do formal training for that at the adult hospitals. What we do have, and it's a mandate, is that every single trainee that comes to us, SRNA or resident or fellow, must have gone through our difficult airway training at our SIM center. And there is I don't know how many hours in fiber optic muscle memorization stuff. If they don't have that, we don't teach it. Okay. So here's how we do this in adults, and this is how I do this for teaching, and then exactly to management is what I've done is we have now raised the bar on fiber optic intubation. I have to admit my bar wasn't very low in the first place because I was trained by Bob Wood, who's a pulmonologist, who's now emeritus at Cincinnati, and it's Tsuru Motoyama, who's the pulmonologist, pediatric anesthesiologist. And we had all spent in training, we spent a week doing fiber optic intubations that we paid $600–700 for, and we did this years ago on primates. Okay, they don't offer that at the ASA. You get to look at a mannequin with a cup of coffee in your mouth. That's a joke, I'm sorry. This is what you can do in your training institution, and you can move it. We train basic skills with very little, almost nothing that you don't have in your room, and to make this skill high. And what do we use? Of course, we have to have mask management. We want spontaneous ventilation, either awake or anesthetized or topicalized. In children, and maybe adults, but certainly children, you get an effect of using some CPAP to open the airway. I've got lots of videos on that too that happen to have without IRB approval. And I love lidocaine. Okay, lidocaine is the greatest drug that was ever invented. Okay.
Fiber optic scope's shaft is usually held by the dominant hand. The shaft of the scope is kept straight. The non-dominant hand grips the handle to control rotation, tip to the right or left, and thumb action, tip up or down. Finer adjustments of the tip may be achieved using the dominant hand's thumb and index finger to roll the distal portion of the scope as it is advanced. After the application of Afrin, plus or minus lidocaine, the tip is advanced through the nares, slides past the turbinates, the soft palate, into the nasal pharynx. The epiglottis is seen in the distance as the scope is advanced past the tongue base. Smudging with secretions can usually be cleared by touching the tip of the scope into tongue base or posterior pharyngeal wall. You will see a flash of bright light when the tip of the scope touches mucosa. With the epiglottis in near view, the tip is positioned to spray lidocaine via the scope's suction channel. Appropriate time is given for its action before advancing. Secretions and excess lidocaine may be removed using the scope's suction channel. The fiber optic scope enters the subglottis. The trachea and carina lie ahead. The tip of the scope is advanced, staying in the middle of the tracheal lumen and avoiding contact with the mucosa.
This is a trainee, second intubation.
While maintaining position of the scope right above the carina, the endotracheal tube is lubricated and advanced to the nares. Gentle forward pressure with continuous twisting facilitates passage through the nares and vocal cords while minimizing trauma.
And there are some specialty tubes, you know, for fiber optic intubation.
A 15mm endotracheal tube adapter can be reattached.
So what's different about this for training? Well, look what we've done. This is a dental case. We do 600 to 900 fiber optic intubations a year on our 2,000 or 3,000, okay? And we do them for training. It's a mandate. my trainees, here's an SRNA who's only done sim center, 60 seconds max, intubates every patient, almost everyone. Residents, 30 to 50 seconds. Fellows, I actually have some of them that I have to say, stop, slow down. I want you to look around and see what the other areas are, especially if you get lost. Because if you're in the vallecula or you're some weird place, you recognize being lost, you recognize where you're at. So what do we have here? Spontaneous ventilating patient. After there's continuous spontaneous ventilation, I put a lubricated nasal airway in the opposite. If I couldn't put it in the nose, if this really was a clinical patient, I actually have old ether hooks, but you can jerry-rig an oral ray, put them in the mouth. I put an op site over it because all those intubating masks are expensive, and they're usually got the holes in the wrong place for kids. Put an op site over the mouth. Now I can let them continue to spontaneously ventilate. I control the anesthetic percentage in these trainees or those that would allow a GA with spontaneous ventilation. And I can control that completely from my anesthesia machine, and I go and attack the opposite areas. Okay. Now obviously I only showed one or two of the lidocaines. If you were really doing this clinically, and especially a topical sedated patient, you would be taking a little bit more time, and you want lidocaine to work at every single layer. Are there other drugs to add? Sure. I love, in children, for this reason only, either the younger ones, Demerol, because I can dilute it and not overdose, or if it's an older kid, I'll start to give small doses of fentanyl, okay, with my Narcan already drawn up in line, my rescue drug in case I make a mistake. Okay, so this is a technique that we can use for fiber optic intubation, either GA, spontaneous ventilation, topical, or sedated. Okay, we are using this, and what it's done is, first of all, our dental person said, first of all, we've not had any turbinate injuries because it's not being pushed blind. And in comparison to the time it takes for our senior CRNAs at the Surgery Center to do an oral laryngoscopy, we are actually, trainees are faster, okay, to do a fiber optic intubation than the nasal intubation with a laryngoscope that hangs up and twists and turns and flexes the head and do all these other things. So we use it for a technique. It's not in their way. It doesn't make the surgery longer. And it set the stage for an unbelievable base of skill set when the really bad airways come in, our traumas and our congenital abnormalities. Okay, so I have one more I'm going to show you, and I really am out of time. Oh, what drug would you add today? I would add dexmedetomidine. Okay, I have no vested interest in any drugs. Okay, but again, that's a drug that you would add. I just don't think you can, we're actually going to call it quits for those two. I don't think you can do a pure dex lidocaine intubation in a child. I've tried it. This is anecdotal. I was up to 6 times the published dose in adults, and they were walking out the door, and so I figured that this should be not my approach. So their pharmacology is obviously different, but there are other drugs you can add. We do fiber optic topical sedated intubations in all ages if it's the safest technique. We've been doing it for 30 years. Most of the pediatric training centers say you can't do a fiber optic awake sedated intubation. That's what CHOP said 2 years ago when you can't do that. I said, but I've been doing it for 30 years. You can't do it. Okay, we're not having a conversation here. We're just going to like this. Okay. All right, I'm going to quit because I got the sign that I'm out of time. Any questions real quick while I pack up? Yeah?
What are your views on standing on top of the patient versus in front of the patient for fiber optic?
Well, I think anesthesiologists are all comfortable being the top of the patient today. The answer is, for my fellows, they have no idea where I'm going to make them stand, okay? Okay? They should be able to sit next to the patient after they have some some basic wiring with some motor skills. The motor skill says just drive the tip into the hole, and the brain readjusts when you have a fairly large experience. We teach it above the head. But I mean, there are cases where the best approach, because the kid was, a teacher Collins, they couldn't intubate him this technique, and they woke him up, they brought him back, and I had some suggestions. I said, you know, he's not dying at home. I said, keep him completely awake, topicalize him, let him think he's moving his tongue forward. Because you and I couldn't see it, but when he was awake and sitting forward, he could tone that tongue enough that they actually could get past it. And he was sitting up, if not leaning forward, and they intubated him right away. Okay. All righty. Very good.